So, John, dear colleagues, good afternoon and welcome to this session, which is dedicated to the management of calcified lesion. My name is Michael Haude. I'm from Neuss in Germany, and I'm your facilitator for the next 45 minutes. So I would like to give you a short introduction into the topic of field. Can you go to the next slide, please? After sharing my potential conflicts of interest, next, please. I would show this kind of coronary image where we see that there is already on the pure angio a lot of calcium within the flow of the coronary artery, even before the contrast is going to appear. This is a patient who is for decades on chronic hemodialysis. And we know that if we need to intervene in these kind of heavily calcified lesions, this is a real challenge, which is, by the way, associated with a higher complication rate and also a lower success rate. Next, please. We know that angiography is not giving us the full appreciation of the extent of calcification and of the distribution of the calcification. Intercoronary imaging, such as OCT or intravascular ultrasound, including virtual histology, really allows us to get a better visualization of the calcium within the arterial wall. Now, next, please. The therapeutic issue is that if we start to dilate these calcified lesions, sometimes we are not able to do so. Even at higher pressure, 23 atmospheres with this non-compliant balloon, you see that we were not able to open up this kind of heavily calcified lesion. And that is the challenge, what to do in a situation like that. We're going to have a dedicated armamentarium of devices that can address this scenario. These are non-compliant balloons that can accept super high pressures up to 40 atmospheres. It could be cutting or scoring balloons. And also nowadays we have the option of a lithotripsy balloon in order to change the compliance of the underlying heavily calcified stenosis. And then we, of course, have the ablative technologies such the laser, and for decades rotational atherectomy and the orbital atherectomy. And next slide. With this session, we would like to focus on that Diamondback 360 coronary orbital atherectomy system to address heavily calcified lesions. Next, please. So the session objectives are first to see the optimized outcome of the orbital atherectomy system for severely calcified coronary lesions. Second, to understand how orbital atherectomy can fit into the daily practice within calcified coronary lesions, and then to learn more about the integrated approach to PCI in coronary calcified lesions. Next, please. With the session flow, we're going to see two case presentations. We have the option to have a discussion after each of these case presentations. You as the audience, you can pose questions to the chat box and we try to address them as good as possible. And then at the end, we're going to have a session evaluation and wrap up here. So without taking further time, I would transfer to the first case presentation by Dr. Alahmar, who's dealing with a heavily calcified lesion in the left main.
Yeah, good afternoon, everybody. My name is Albert Alahmar. It's a pleasure to present this case to you. I hope it was live. Nonetheless, in this current circumstances, we can live with virtual. The case today, I have no conflict of interest for this particular case. And I'll start with a small introduction as to why we do this case. What's the message we're going to relay to all of you? As you all know, there are multiple publications demonstrated that the heavily calcified lesions exceeds in some series 20% of all angiogram that we do on a daily basis. So it's not small burden that we are faced on a daily basis. And the reality of that is we need to be more cautious, be more prepared to deal with those challenging cases in order to achieve optimal results. I'll show you some data to support this. This is the stent failure in general is bad for our patients. Any patients who had instant restenosis or stent thrombosis, as you can see here, there is a quite significant increase in hard endpoints. We're talking about death, myocardial infarction, with hazard ratio between patients who ended up with target vessel failure and who didn't. There is quite significant proportion. As you can see, there is a hazard ratio indicating that we're not doing our patients any favor when the stent fails, and we increase their mortality, let alone their symptomatic issues. We all know that the intravascular imaging is crucial to improve our PCI outcomes. Again, this is a series related to 12-month outcome. And again, we're looking at clinical outcome. And patients who received angioplasty guided by intravascular ultrasound and who did not. And you can see the difference between them, quite remarkable, really. Yet, I'm surprised, and you go to any meetings in the world, you do see the number of people using intravascular ultrasound is still a small proportion. You've seen this large data meta-analysis from 11 drug-eluting stent studies showing the benefit in terms of mortality and MACE in stent thrombosis. The calcium, the presence of calcium, we know it's a predictor of worse prognosis. In thousands of patients, we had 7 drug-eluting stent trials with over 6,000 patients in which they had independent core lab analysis for angiogram at Rotterdam under Professor Patrick Soros. And without a shadow of a doubt, the presence of calcium is a predictor of bad outcome. We're talking about mortality, death in the heavily calcified arm of 10%, whereas in the non-calcified arteries, it's 4.4%. This will mount into 22% if we add the myocardial infarction compared to the other arm, and the death MI, any revasc, they follow the same pattern. So we really do have strong evidence how important it is that we prepare our patients' coronary arteries lesions properly before we deploy our stents. This is just a striking slide. And as you can see in a multi-publication, the number of lesions, I wouldn't say operators, that have severe calcification, as you can see here, the number is 114, only less than 20%, they had rotational atherectomy or lesion preparation or debulking. Knowing all the data that we've mentioned so far, I think there is more emphasis towards debulking our lesion in heavily calcified because we can reduce mortality. We're talking about hard endpoints here. We know about the traditional rotational atherectomy, and the new boy on the block is the Diamondback 360. I'm not sure I agree with the name, but the CSI device is really promising, and it has some advantages over the traditional rotational atherectomy. We know it does sanding the calcium in 360 degrees with less impact on vessel dissection or complication. We've seen the calcium modification in the rotational atherectomy, and as you can see here, I don't know whether the mouse is playing, you can see the breakdown, and the calcium is almost on 360 degrees. So there is certainly advantages over the traditional atherectomy. And certainly the orbital atherectomy is made its way rapidly, I think more than any device we've seen over the last 20 years. This is the algorithm for the use of coronary atherectomy, as we're all familiar with. I think the top half of it is whether it's PCI or CABG. It's irrelevant. We all do the same. Nonetheless, when we do the angiogram, we need to pay more attention to the calcium burden in any arteries we are dealing with. And the minute we exceed the moderate degree, we have low threshold towards atherectomy in those patients. I think we all agree that probably IVUS or OCT intravascular imaging to define the calcium will always help. We have a new scoring of the calcium, 360 degrees, the depth of the calcium. So we have more criteria now. We are looking more towards identifying the calcium and deal with it, given the previous studies showing the poor prognosis when we don't do that. We probably, all of us, we've seen the Eclipse trial that presented at TCT, and it was really showing some promising results in favor of orbital atherectomy. We're talking target vessel failure, we're talking about MSA, and as you can see, the randomization was done in a sizable number of patients, 1-to-1 Victorian, with, again, very, very educated. When he presented the data, it was really promising. So without going further in terms of introduction, I'll show you the case that we did in our center to demonstrate some of the advantages of this technology. Patient is 78 years old, male, hypertensive with dyslipidemia, had a crescendo angina for over a few months' time, transthoracic echo demonstrating preserved left ventricular systolic function. His coronary angiogram, I'll play it shortly to you, showing you the extensive disease. He was offered surgery given the severe three vessel disease. However, he categorically declined, and the heart team reviewed the images, and we agreed that we have to do something for him. Therefore, we agreed for high-risk PCI with the hemodynamic support. I'll show you the images. I think they are playing now. This is the right coronary artery, has severe osteal disease. It's a dominant vessel, almost retrograde, filling the left system. And I brought him as a first stage with intra-aortic balloon pump support. We were planning Impella, however, due to the financial cost, we elected for intra-aortic balloon pump. The procedure went successfully. We stented his osteal right coronary artery with the guide catheter, as you could imagine. 90% of the time in the aorta, actually, there was no way of engaging with the right, as his blood pressure will slump down to 20s the minute I engage my guide catheter. We're stented, and it looks nice results. So we stabilize the patient by doing the right coronary artery, and my plan to bring him back to address his left side. I'll show you the left side diagnostic pictures. This is the final picture of his right coronary artery with a large 4-0 stent in his proximal RCA. And you can see the retrograde filling collaterals towards his left system. The left system, his left mainstem, his LAD and circumflex, they look really abysmal. Heavily calcified, extensive disease, including distal left main and occluded CTO of his obtuse marginal. So my plan was to address his left mainstem and his LAD using orbital atherectomy. I was guided, and then we address his circumflex at lateral stage, given the size of his circumflex as a small non-dominant vessel. This is another with the guide catheter. As you could imagine, this is a patient, remember, during his diagnostic angiogram, which was done in a referring hospital. The minute they've done a diagnostic test for him, during the diagnostic, he almost arrested the patient at the time, and they stopped completing the diagnostic pictures. You can see his distal left main, heavily calcified, with a very, very small rim. The area was less than 3 square millimeter. The LAD diffuse disease all the way beyond the bifurcation with sizable diagonal. So my plan from the start is in a 6 French guide to use the orbital atherectomy. This is one of the advantages using the orbital atherectomy. You only need single device for all arteries, regardless of the size, from 2 millimeter to 4.5. So this is one big advantage compared to the rotational atherectomy. I'll show you the run of the, I'm in no control of the slides, by the way, but I can see them on the right-hand side. And I think this is perhaps the pullback on the rotational orbital atherectomy. And as you know, this is a two-way device that we can drill forwards and backwards. And so I've done it to the twice, one for his LED and left main using IVUS guided. And I hope I can play the IVUS for you to show you the calcium breakdown in his arteries. Now, following the orbital atherectomy, it was straightforward beyond that point, balloon and stents. We deployed 2 long stents in his case. The one in the left main at the end was with the pot, obviously, towards the end. And you can see the final results in the caudal view and the cranial, demonstrating quite nicely. It would not have been possible to do this without atherectomy, and specifically, I would emphasize in this session on orbital atherectomy. If I can show you, I hope the slides are presenting quite well to everybody. This is perhaps the cranial last view. At that point, I was in the mood to do the CTO, but I thought enough for the day. We'll bring him back for another session for his small circumflex using hybrid procedure. I'll show you just basically the IVUS. This is the IVUS run from distal to proximal. As you can see, it's a 360 degrees heavy calcified lesion with a very thick calcium beyond 0.5 millimeter. Per the definition of calcium, it's severely, heavily calcified. And I'll show you the still images before and after in the left main, where you can see the breakdown. I can't use the mouse to demonstrate this, but in the second slide on the lower part of the slide, where you see the IVUS after the orbital atherectomy twice, there is quite extensive breakdown and the calcium facilitating, making the whole, almost the left main as a cylinder. And as you know, when we started, it looks more elliptical, heavily calcified, ugly looking, whereas after the orbital atherectomy for any stent, it looks much improved in shape and size. I'll just conclude here for you all. And I'm hoping there was some question at this point. The take-home message, I think, for everybody, orbital atherectomy in calcified left main stem is feasible and effective in lesion preparation with potential better calcification breakdown. Indeed, it's a superior debulking with only one crown. Increasing speed generates larger orbits and allows to treat larger vessels like left main stem compared to traditional rotational atherectomy. The final one is the support of intravascular imaging may be helpful to guide lesion calcium breakdown with orbital atherectomy system. I think becomes mandatory in left main stem using intravascular imaging. One last point I think I would like to emphasize on it, using the radial versus femoral. As we all know, anything beyond 1.5 Ber in traditional rotational atherectomy requires 7 French, and quite often we end up going from the groin using femoral artery, increasing risk of bleeding, whereas this technology requires only 6 French guide catheter for all vessels, including left main stem, which makes it more feasible to do it from the radial artery, reducing risk of bleeding with its imminent mortality benefits. I'll stop at this point, and I don't know whether when we go live will be some questions. I can take them, more than happy.
Welcome, Dr. Alahmar. We're going to have some minutes of time to discuss your case, and thank you very much indeed for a very educational presentation. So I think also the audience like to know, how does this treatment technique with the orbital atherectomy differs from the rotablator?
Yeah, thank you very much for having me. Indeed, as we know, I mean, probably the new concept for orbital atherectomy is the fact that it's a mountain diamond coated crown which uses centrifugal force to orbit the artery. As compared to the traditional rotational atherectomy, we know that it's diamond tip burr that spins concentrically over the wire. Indeed, it's one size device in the CSI or orbital atherectomy, 1.25 millimeter, whereas in the traditional one, we have different sizes started from 1.25 to 2.5. There are more reports and studies demonstrating that we break the calcium better using the orbital atherectomy. However, indeed, we're all waiting, I think, perhaps for the Eclipse trial outcome to see the real difference in a randomized fashion, one-to-one, looking at the outcome between those technologies.
Thank you very much for that answer. Continuing in that line, when would you not consider to use orbital atherectomy and why?
Absolutely. It's a very good question indeed. And we know every technology has its limitation. I think for the orbital atherectomy so far, it's primarily the osteal disease that we are still hesitant to use it, although I've seen it used in different places. As long as they say you can get the cone in, then you should be able to use it. Apart from, I think, osteal disease, in the majority of the calcified lesions, we are able to use it. Small or large vessel, it's very, very effective.
Okay, thank you for that clear answer. One aspect is the importance of intracoronary imaging when we talk about calcified lesions. So my question is, how often are you using intracoronary intravascular imaging, and how is it influencing your treatment plan in order to choose to move to orbital atherectomy?
Yeah, that's... I mean, I was raised in an environment. I worked with Tony Gershlich for quite a few years when I did my fellowship, and I was raised in the form of using intravascular imaging for almost every lesion. So I'm a big believer in using intravascular imaging, whether you use intravascular IVUS or FDA or you use the OCT, it's entirely down to yourself. But in my practice, particularly when it comes to left main, to calcified arteries, I have very low threshold to start with it. At least you study, you clarify the anatomy, and then make the decision that you need definitely debulking. The orbital atherectomy started to merge as the potential new technology with 360 degrees, much calcium breakdown, perhaps a better vessel ready for the stents. But as I said, again, we'll wait for a randomized trial to confirm that fact. It's easy to use, I think, and I think the intravascular imaging after post also as probably the atherectomy post-stenting is probably crucial when it comes particularly to left main stem.
I do have one more practical question. How do you know when you are done with the lesion preparation when you use the orbital atherectomy in your calcified lesion?
I think it's the billion-dollar question, but the intravascular imaging will guide me into, have I done enough, or we still need to do more? In the case that I've shown, although the slides were limited, using the intravascular, I used IVUS. Using the intravascular ultrasound resulted in me coming back again with the orbital atherectomy and prepare the lesion again. So I think the answer to your question is using intravascular imaging and be happy with your results before you deploy any stents.
And a final question, a quick one and a quick answer. Do you also always need to post-dilate when you did the orbital atherectomy before sending the DES in there?
Yes, we still, I think, we tend to post-dilate all the time. And again, I use the intravascular imaging post-stenting to look at the stent opposition. But I have very little threshold to post-dilate. I think if we probably using more learning about the technology and see the outcome of the calcium breaking with the stent outcome, we may be in a position to say there is perhaps in the future, the stent well opposed may avoid probably doing post-dilatation.
So thank you very much, Dr. Alahmar, a very elegant presentation and good Q&A section. So I'm happy now to move to the second case presentation by Dr. Aboushokka, who's giving us a case in a bifurcation lesion.
Hello, everyone. I'm Wael Aboushokka, consultant interventional cardiology from Al-Qasimi Hospital, Sharjah, UAE. Today, I'm presenting a case of calcific bifurcation lesion and how to manage this kind of cases. I have no conflict of interest to declare. Our patient is a 70-year-old patient. He is an non-insulin dependent diabetic, hypertensive, ex-smoker, dyslipidemic. He presented with acute coronary syndrome and non-ST elevation, MI. He is a known case of COPD, and his echo showed left ventricular ejection fraction of 45% and positive resting segmental wall motion abnormality with no significant valvular lesions. His coronary angiography showed normal right dominant right coronary, and the left system was the left main was normal, LCX was normal, LAD showed non-significant disease from its ostium with severe lesion at the proximal segment with bifurcation into with D1. And the severe calcific lesion extending to the distal segment. And if you can, in the PA cranial view, you can appreciate that the lesion extends up to the distal third of the LAD after giving most of the important branches, the big septal branches and the diagonal branches. And in the RA coded view, you can appreciate the disease in the LAD. And I think it is around 40 to 50% that it should be treated if you go to PCI. So what is the treatment options for this patient? CABG, PCI, and if it's you chose PCI, what is the strategy that you will adopt? The case was discussed in the heart team meeting, and due to it is a single vessel disease, LAD only, although it's a bifurcation calcific lesion, and the presence of chronic obstructive lung disease, and the patient was on inhalers. We decided that PCI seemed to be the proper way of management. So for the PCI, so what is the strategy for it is a long calcific lesion? We decided to go for a new technique to protect the diagonal. It's called the sleeving technique, that we will discuss in details throughout this presentation. But first, I want to enlighten or highlight the problem of severe calcification in coronary artery disease, and it presents like 6 to 20% of all PCIs that is done around the globe. I mean, like 15%. And this affects the long term, not only is a short term, but also the long term results of PCI. As mentioned in the retrospective analysis of the Acuity and the Horizon AMI trials, the 1 year mortality might reach in severe calcific lesions to nearly 20%. And another meta-analysis of 7 drug-eluting stent trials, the 3 years mortality was around 32%. The problem of calcification is not only delivering your stent, but also the stent expansion, proper stent expansion, and malapposition and edge dissections. These are 3 factors that you have to take care of them. And unfortunately, it can be missed easily if you are using only angiography. And most of these cases, I would recommend using intravascular imaging. In this slide, I just wanted to see to show you how this orbital atherectomy works and how it orbits around the vessel wall. This allows it to treat vessels with the same burr from 2 to 4 millimeter diameter. And the nice thing about orbital atherectomy also that it does not only work on the intimal calcium, but also this pulsatile force from the orbital movement makes cracks in the deeper calcium and allows the vessel to expand and move much more normally. So let's go back to our patient. To do the sleeving technique, you need at least 8 French guiding casters. So we used femoral approach to engage an 8 French XP caster to the left main and managed to wire the LAD and the first diagonal. And over this, the side branch, here is the diagonal. We put a microcaster. I think it was a teleport control in this case to protect the wire in the diagonal. And then you start doing your atherectomy. The most important tips and tricks here. First, that as you are using a microcaster in the side branch, it's recommended to only to use the 80 the lower speed, the 80,000 RPM per minute. The other thing, during the rest between runs of atherectomy, it's better to change the side of your microcaster, either by pushing it forward a little bit or pulling it back to change the area where it contacts the atherectomy device. And for the orbital atherectomy, you usually do 1 millimeter per second advancement, and it needs you need to use all your senses, the tactile sensation and the hearing also. Once you hear changing the sound of the atherectomy device, then you might leave it to work more at this area because there's a lot of calcium until the sound start to come to the normal again a little bit. Anyway, we managed to do atherectomy to the LAD. It took some around 15 to 20 minutes because it was a very long lesion. And then we started ballooning the LAD and the diagonal. We decided to use a leaky crush technique to treat this case. We stented the distal LAD first, distal to the bifurcation to protect the LAD. And then for the diagonal, we opened the ostium of the diagonal using a cutting balloon, and then we stented it using 2.25 23 stent that was crushed using a 3/0 non-compliant balloon in the LAD, and then stenting the LAD using a 3/5 23 with a final pot and kissing balloons with acceptable end result. Our take-home message here is severe coronary calcification is one of the hindering factors affecting the outcome of PCI. Coexisting through bifurcation lesion adds a challenge to your PCI procedure. Side branch sleeving technique offers a reasonable solution, especially in if you are managing bifurcation with a big or an important vessel, especially in left mains, LAD, big diagonal, the big side branches that you need to protect. And using the Diamondback 360 device in these cases with the branch sleeving technique offers a reasonable solution for these cases. And I wanted to mention that using also in my home take-home message, using intravascular imaging is crucial in most of the calcific lesions to put a strategy for your case. Although I didn't use in any intravascular imaging in this case because of reimbursement issues, but usually I use it more than 99% of my cases, not only the calcific, but all chip cases. And choosing with the presence of a lot of equipment in management of calcific lesions, you need to choose the proper device for each case. And thank you, everyone. And we hope to see you next year in the way after, in the next Gulf PCR after this COVID era. Hopefully it's finished. Thank you.
So, Dr. Aboushokka, welcome, and thank you very much for sharing this very interesting and challenging case, in particular sharing the sleeving technique that you applied here. I would like to also address some questions to you. If you look at the armamentarium of different devices that we have to address calcified lesions, apart from the ablative technologies like the rotablator and the orbital atherectomy device, nowadays we have the intravascular lithotripsy. Where is the indication in your particular thinking for the case that you showed us to choose the orbital rather than one of the other ones?
First of all, I would like to express my deepest gratitude for the Gulf PCR Committee and the PCR Committee for this wonderful event. Really, that is a very good question, and I'm happy that you asked me about it, because in the last few years, we are having more equipment and devices for management of calcific lesions. And for every case, you need to decide which device you will choose. Rota, orbital atherectomy, lithotripsy, shockwave. And I'm blessed that I work in a place we have the whole setup from balloons, cutting balloons, scoring balloons, to the lithotripsy. Actually, in left main cases, especially, and where you need a very big, diameter, where you can, the CSI orbital atherectomy give you a very good choice. Although orbital, also the shockwave, they have big diameters, but still our experience is more with atherectomy devices. Shockwave, it's really a good device, but sometimes it's unpredictable, the result of shockwave, you have big dissections sometime and intravascular hematoma. Sometimes the device is bulky and it would not cross. And in some cases, we have 2 cases that we use both atherectomy plus shockwave. So usually, for me, I prefer atherectomy unless if there is a contraindication, maybe a single vessel, single remaining vessels that you are a little bit worried of distal embolization and no reflow. Although we can manage this with using hemodynamic support with impeller.
If you do allow me to focus a little bit on the calcified lesion characteristics, are there dedicated characteristics where you prefer the orbital atherectomy device over the rotablator?
Usually, in ostial lesions, I would prefer it because it's dual way of working. You can use it backward when pulling back the device to treat it ostial left main or ostial RCA. In big diameters, 4 to 4.5. It works up to 4.5 actually, but to go 4 to 4.5, you need to increase the speed to 120 RPM per minute. And if you have deeper calcium, that by intravascular imaging, which is you can identify it by IVUS, but it's better by OCT to identify the deeper calcium.
Okay. A practical question, is the setup of the system easy with respect to the stuff? So can you do it ad hoc, or do you need to prepare upfront?
In the beginning, we started using it now 2 years back. In the beginning, we needed help and support from the company, like product specialists to be around. But nowadays, since 1 year, we're doing it very easy. The whole stuff is very comfortable doing it, and it takes no time.
So, Dr. Aboushokka, thank you very much for sharing your personal experience with this technology. And actually, I think it's now time to wrap up. And if you can provide me with my take-home message slide, I would appreciate very much. So I think what we have learned in this symposium is, first of all, calcium severity is a predictor of worse PCI outcome was documented in many drug-eluting stent trials. Due to its mechanism of action, orbital atherectomy allows to treat every kind of calcified lesion with only a single device. I think this is the big differentiator against the rotablator. The orbital atherectomy in calcified left main stem and true bifurcation stenosis, so really challenging lesions, is feasible and effective in lesion preparation with potential better calcium breakdown than with balloon angioplasty alone. Scientific-wise, we heard about the ECLIPSE trial, which is ongoing and still recruiting. A large trial of 2,000 patients randomizing 1-to-1 orbital atherectomy versus conventional balloon angioplasty prior to implantation of a drug-eluting stent, with the primary endpoints of post-PCI minimal stent area in a subgroup of patients, 500 by OCT, and second, the 1-year target vessel failure up. Very interesting to see whether it turns out that orbital atherectomy here brings both a beneficial as well as a mechanical aspect in that scenario. With having said that, it's my pleasure that I need to close down the session. I'd like to thank our 2 presenters for their valuable and educational presentations, and you, the audience in particular, for choosing to join this session. Finally, I'd like to thank Orbis Niche for sponsoring the session. Having said that, I wish you a very fruitful rest of this year's Gulf PCR. Thank you very much.